Welcome to San Luis Podiatry Group. This is Dr. Chris Byrne. I'm happy to spend time on a DVD presentation discussing the most common cause of adult heel pain, which is plantar fasciitis. Plantar fasciitis, or heel pain, as we've discussed, is pain and inflammation at the attachment site of the plantar fascial ligament, which attaches to the bottom of the heel bone. This is an anatomic rendering of the bottom of the foot with the shown attachment of the plantar fascia on the bottom surface of the heel bone. The plantar fascia stretches out from the attachment of the heel bone to the base of the toes and is a very supportive ligament of the foot. Plantar fasciitis, again, is a very common cause of foot pain in adult patients, with up to 10% of all foot and ankle care provided in specialist office related to this diagnosis. Fascia is a very broad ligament that attaches to the bottom of the heel bone. The X demarks the area of maximal tenderness that most patients have. What we see with regards to the foot is the plantar fascia, as it's the soft tissue attachment to the bottom of the heel region, forms almost a triangle in relationship to the bony architecture. As a patient stands down, there's a tendency to flatten the foot or overpronate the foot. And when that occurs, there's a significant amount of stress placed on that ligament as it's attaching to the heel bone in this region. And in some instances, the development of heel pain can occur. Plantar fasciitis, itis represents inflammation of the plantar fascia as it attaches to this region. There's also a small attachment to this region of the heel. Patients will tend to have pain with initial rising, so getting out of bed in the morning or initial first few steps in the evening after having sat down. Treatment is a true balance of shoe and orthotic therapy and anti-inflammatories. The shoe and the orthotic can't be underemphasized over the period of time of treatment. I ultimately try to prevent patients from doing any barefoot walking, even getting out of bed in the middle of the night, with using a good supportive shoe and an orthotic over the period of time. Anti-inflammatories, including Advil or Aleve or prescription strength anti-inflammatories, cortisone, and ice are the three main ways to decrease the inflammation. Secondary treatments including short-term use of casts, night splints, splint that you wear at night, as well as taping techniques. The shoe and the orthotic work together to decrease the stress on the plantar fascia. I generally recommend that during acute phase of treatment that you use a supportive lace-up style running shoe with the use of the orthotic. Treatment with regards to plantar fasciitis has an influence on the use of anti-inflammatories to decrease the inflammation, but more importantly, biomechanically controlling the foot and ankle motion. What we're attempting to do is decrease abnormal foot pronation. And as I mentioned, the lengthening of the plantar fascia and the stress on the plantar fascia. A shoe and an orthotic, oftentimes an off-the-shelf orthotic, or in this case a custom orthotic, can be used to help stabilize the foot and decrease some of the tension forces as well as the downward stress on that plantar fascia. A simple icing technique is to place a frozen water bottle on the ground and actually roll your heel in the region of pain over it for several minutes. If you can do this twice a day for the first week to 2 weeks, it'll be very helpful. Many patients are very fearful about the use of cortisone. Cortisone is a very effective tool in decreasing the inflammation and associated pain. There are very few side effects to cortisone in any soft tissue. Cortisone over a long period of time can thin the fatty protective tissue. On the bottom of the heel you have a very important fat pad that helps protect and decrease impact pressures. Very rarely will the cortisone cause any thinning of the fatty tissue as it's attached, on the bottom of the heel. Cortisone is introduced with a local anesthetic in the form of a shot. The cortisone itself is injected into this region of the heel and injected from side to side. Very safely, we can inject 1 up to 3 cortisone injections within a 6-month period of time. Most patients require 1 cortisone shot. Cortisone itself is extremely instrumental in helping relieve heel pain and getting you to adequate recovery. Night splints can be used as an adjunct to treatment. They're typically not used as a first-line therapy because they tend to be difficult for some patients to wear at night. Clinically, night splints have been shown to be quite effective in reducing the pain with initial weight bearing out of bed in the morning. By keeping the foot stretched out at close to 90 degrees to the leg, it tends to take the stress off of the plantar fascia, which helps decrease inflammation. Removable cast boots or cam boots can occasionally be used to decrease the stress off of the plantar fascia only as needed. Half stretch exercise twice a day for 1 minute to 2 minutes at each setting will be a helpful treatment tool for you. The calf muscle and the tightness of the calf muscle is very much associated with the development of many foot and ankle related problems. Specifically, the stress and the pull on that plantar fascia is intensified for patients who have a tight calf muscle. So as a routine part of treatment, with the knee straight and the heel on the ground, both feet pointing straight against the wall, we're actually having the patient lean into the wall to stretch this calf muscle. You should feel the pull in this region of the calf and sometimes a little bit lower. Plantar fasciitis is an extremely disabling temporary injury. As we said, it's the most common cause of adult heel pain. The focus in recapping treatment are twofold. The first is to decrease the inflammation. Ice, the short-term use of oral anti-inflammatory therapies such as Advil or Aleve, and even the use of cortisone used selectively is the combination of anti-inflammatories to decrease the pain. Secondly, followed by biomechanical control, and that's again the temporary use of a firm arch support with a supportive shoe such as an athletic shoe. The combination of the shoe orthotic therapy and compliance with that, limiting the amount of barefoot walking, as well as the anti-inflammatory therapies work together to help decrease the inflammation in the tissues, allowing full recovery.